Okay, well, I hope the other presenters in this session can come on the stage and accept questions. And is Dr. Kawar still online? I don't know if that's possible, but
yes, I'm here.
He is. If you could accept, yes, I think I see. Okay, good. So do we have questions? We have two microphones. Oh, only one. Sorry. Oh, there's one missing there. Yeah. Okay. We have a microphone on this side.
Hi,
yeah.
Steve Ash again. Thank you all for wonderful presentations. It was really, really informative. This is for Dr. Vollenberg. I always remember things much better if I really understand them. And so explain to me how it is that the electromagnetic waves shake the albumin more than the associated chemical on the albumin. I would think if it was a simple interaction electronically, the smaller, more charged and particles would move a lot more and the albumin would stay still.
Yeah, we are not entirely sure about that mechanism yet, but we know that albumin is negatively charged, I believe. And the idea is that if we shake that hard enough, or maybe because they have a difference in size and weight, they get shaken differently, and that difference in movement might dislodge them somehow. But that at least the electrostatic bond between the P-bud and the albumin is interrupted there. And we have ideas to study the more fundamental part behind this interaction by maybe trapping albumin on some, it's called a quartz microbalance, which is a vibrating cantilever. And if you stick the albumin on it, then you get a resonance frequency. And then if the P-bud dislodges, you have a change in mass, and you should be able to see that in the resonance frequency. So by doing more single molecule studies, we might in the future get more information about this mechanism. But yeah, for now we try to explain it by shaking them and dislodging it like that.
And the basic interaction is because of the charge of the particles? Is that why they interact with the radio waves?
Yeah, so things that are charged, they can interact with the electromagnetic field. So the protein that has, as far as I know, a negative charge is therefore influenced by the field and can shake. Yes.
Mm-hmm. Well, thank you. I also had one for Dr. Kawar. Question from Dialysis. Is he here?
I'm here.
Oh, yes. Hi.
I see.
So you have two modules, one sort of a patient module and the other is the dialysate source. Is that right?
Correct.
You mentioned that the dialysate could be reused. So what kind of work are you doing in sorbent chemistry to regenerate that dialysate?
Yeah, we have a sorbent solution. If you recall, the machine we showed had a white portion, which is the front of the machine. The gray portion is the RO dialysate production. Our system is modular so that the patient interacting space, the GUI and the disposable, can stay constant, but we can switch out the DG, which is what we call the RO system, for a sorbent system too. Our plan is to bring our current devices we showed you to the market first, and then we have a sorbent solution similar, I think, to what Neo Kidney was talking about, with innovations that have improved sodium control and pH control back to the market so that it would be an all-encompassing platform.
Thank you to all the doctors and engineers who talked on this topic. Dr. Kawar, as I introduced myself earlier, my name is Eric Ditchman. I've been on dialysis mostly home since 2001. So as it relates to that, first of all, with Dr. Fizell's amazing discussion, I feel like I shouldn't even mention the word dialysis. But I have to dialyze tonight, so until that comes to on the market, I will talk a little bit about dialysis and diality, which I found fascinating. But to the other good doctor's points, I have 90 liters of dialysate when I got to my room yesterday just to be here at this conference. I was in San Diego earlier with my family. I had 140 liters of dialysate. The dialysate follows me if I'm to go anywhere. So I appreciate where we are going with reducing the amount and recirculating. I wanted to just thank you, Dr. Kawar, for being patient-centered, and really for any company or initiative to call them patient-centered. You have to have the patient at the beginning, at the design set, and you have to keep us there through the entire process, because there's a lot of lip sync to patient-centeredness, and if we're not there, you're not about us. Your heart might be there, but you're not going to hear how your technology is going to react when we want to use it. I always remember that I'm not a patient, I'm a consumer. So with the diality, basic question, is it point of use, or is it dialysis on demand? Is that what diality will be?
Thanks, Eric, and appreciate you and all the other patient advocates and patients that come to meetings and help us inform what we should be creating, because it is in the end for patients like yourself. The machine that we're coming up with first is a real-time dialysate production machine. There are some unique properties about our machine, which I think, because we're not approved yet, I don't want to get into too much, but I think there are ways that we could utilize dialysate more effectively and potentially reuse it. The final solution, there would be a sorbent solution, but in what we are bringing to market, it would be a traditional machine as most people think about it, but much more compressed and still providing the dialysate flow in real time at high flow rates. So one of the challenges technically, Eric, is trying to provide in-center dialysate flow rates when you're not in a center. And that is a technical issue that we have solved. And the issue you're talking about is how do we use less dialysate? I think there's some great innovation coming and hopefully many more to come.
Thank you. Just one quick follow-up. Could I use your machine here in my hotel room? And just so you know, on the high rates, I run at 220. So I also need to make sure I'm being able to use it at the low rates. So, but first of all, could I use it in my hotel room?
So when the machine that we use right now will be one that we'll need to, because it produces dialysis in real time, we need to know the source water. And if you're using EPA grade water, which is what most companies test to, you know what the delta is and you know what you can test to. What's challenging is using source water and not knowing what its quality is. And that's a challenge that nobody's fixed yet. There are ways that sorbent dialysis can in the future improve the quality of source water, but nobody's doing that yet. But to answer your question, yes, we would need to know the source water before we treat it. So in your hotel room, that would be a challenge.
Thank you.
We have a question coming in from Zoom to Dr. Fizell. Is it anticipated that the implantable kidney will have a lifespan of at least or better than a transplanted human kidney? Do you see any limitations?
Yeah, that's a question that we get fairly frequently. And so we've initially been challenged on the lifetime of cells, that traditionally people think of renal tubule cells as having very short lifetime in the dish. The data that I presented to you, for example, on the sodium glucose co-transporter, that was after 46 weeks in continuous culture in our laboratory. So not 10 days, not 2 weeks, not 4 weeks, but close on to a year. And the only reason why we're not still culturing this, I killed him accidentally trying to stress him a little bit. We would like to think about life cycle management in the same paradigm as, for example, pacemakers and AICDs. There's aspects of an implanted device that are incredibly hard on the patient, and vascular access would be high up on that list. And like with the pacemaker's lead insertion, it's the kind of thing that you get to do once. The pacemaker generator exchange is a minor outpatient procedure nowadays. It's located in an easy-to-reach subcutaneous pocket. Quick connect, disconnect, close the pocket, and you go on your way. And we'd like to take the same approach because life is uncertain. Things are going to happen to an implantable artificial kidney. If you look at dialysis access as a paradigm, there's some patients who get one fistula once and they're good for 15 years. There's other patients who get fistula after fistula after fistula and end up with a catheter as their destination access. Everybody's different. I wouldn't presume to say today whether we will have a 15-year mean time between failures. What I'd like to move to is a model like this. I don't want to lose my cell phone. It'll be a hassle. I'll have to spend money, but I'm not going to be afraid that I'll never make another phone call in my life. So what I'd like to do is replace this model of scarcity, where we're focused on squeezing every last drop of function out of a device, to a paradigm where you can replace it maybe at some expense, and maybe at some inconvenience, but not at the threat to the patient's life.
Thank you. Due to time concerns, I think we have to discontinue the. We have to discontinue the talk. So I want to thank the panel and our speakers, and we have sorry.